Today we're going to talk a little bit about post-cardiac arrest pearls. So we got three big topics here. There's sort of three mini lectures in here. I'll give you sort of a broad overview and then we'll deep dive into each thing. So the three things we're going to talk about in your post-cardiac arrest patients are, number one, do we need to send them immediately to catheterization? Number two, do we need to cool these patients? And number three, do all of these patients need to get full body imaging once we've resuscitated them? So we'll step into each one at a time. The first question, the first clinical question in this chapter is out-of-hospital cardiac arrest and cardiac catheterization. So I'll give you a couple scenarios and then we'll start going into the abstract. The first scenario is you get a patient coming into your emergency department with return of spontaneous circulation, okay? They've been resuscitated, you get the EKG and the EKG shows STEMI. Does that patient need to go to catheters to get coronary revascularization? Absolutely. The second scenario is you get a patient that comes in, has return of spontaneous circulation. You get the EKG, but there's no STEMI. There's also no other clear cause for this patient's arrest. Does that patient need to go for coronary revascularization? And the question is a little bit more nuanced. So let's review the literature and see how we would answer that question. So we'll start with abstract number one over here, which is the PROCAT study. This is a Paris study. The first two abstracts that we're going to go through are basically observational studies that started to show a hint of benefit for patients that didn't have a STEMI but went to cath, okay? So before 2019, it was unclear whether or not these patients benefited or not from this practice. Post-2019, we started to get some more randomized controlled trials that gave us a better answer. So we'll start with the observational studies before 2019 and see what those studies showed us. So abstract number one, the name of the study is Immediate Percutaneous Coronary Intervention is Associated with Better Survival After Out-of-Hospital Cardiac Arrest. Insights from the PROCAT, Parisian Region Out-of-Hospital Cardiac Arrest Registry. If you ever hear Rick talking about the best way to write a title, the way that these authors did it, they basically told you their conclusions in the title. Immediate percutaneous coronary intervention is associated with better survival after out-of-hospital cardiac arrest. Now, this observational study included 714 out-of-hospital cardiac arrests. About 2/3 of these did not have a STEMI, and 1/3 of them had a STEMI. In lumping all of these patients together, they found that going to get a cardiac cath was an independent predictor of survival. So the odds ratio was 2.06. Independent predictor of survival. So because this was an observational study and not a randomized controlled trial, because it was an observational study, they were able to establish that there was some association with better survival, but they couldn't necessarily prove that the patients going to cath was the reason that the patients had better survival. Furthermore, in this study, there was no comparator group. So in other words, all of these patients that went to immediate cath, they all went within a couple of hours, or they didn't get cathed at all. They didn't have a comparator group where patients went in a delayed fashion to see, well, if we waited about 10 hours, would it have made a difference? Right? So their conclusions, these Parisian authors, both in abstract number one and abstract number two. Abstract number two is basically they extended the observation period. The first study was 2003 to 2008. Abstract number two, they basically extended the study all the way out until 2013. And they found, again, that in the second study that if you looked at more survival at 30 days and then you looked at survival for 10 years, again, there were independent predictors of survival with catheterization, that you did better, okay? So there's a hypothesis. Going to cath early, whether you have a STEMI or whether you don't have a STEMI, is associated with better survival. Now, in 2015, the American Heart Association looked at these results and they said, well, for STEMIs, there's no question. Class 1A recommendation that all patients out of hospital cardiac arrest achieving ROSC should go for catheterization, no questions. They also said that based on the results of these studies, these associations, that it is reasonable to send patients that don't have evidence of STEMI to also send them for cath immediately. And it wasn't until 2019 in the Netherlands, this abstract number 3 here, abstract number 3, coronary angiography after cardiac arrest without ST segment elevation. This was published in the New England Journal. This is the COACT study. And in the COACT study, this was actually the first ever randomized controlled trial looking at immediate versus delayed cath in patients with out-of-hospital cardiac arrest that did not have a STEMI. Okay? So they took that subset of patients that didn't have a STEMI on their initial EKG, and they looked at, well, why did we randomize them to less than 2 hours immediate catheterization or delayed catheterization? They can wait a little bit. Furthermore, they took not just, which patients do we think would do better? Patients with VF, VT, shockable rhythms, or the patients with asystole and PEA? The shockable rhythms. So a nice thing that they did in this study is they only enrolled those patients where we thought there would be maximum benefit, the patients with VF, VT, shockable rhythms. So they took all of these patients. There was about 550 out-of-hospital cardiac arrest patients that did not have a STEMI, that had only shockable rhythms, and they randomized them to immediate cath versus delayed cath. And what did they find? Their primary outcome here was 90 days survival. They found that there was no difference between the delayed group or the immediate group, that in fact, patients survived just as well if they just waited to get their catheterization, okay? And the mean average amount of time that patients waited to get that cath was about 110 hours. So less than 2 hours for immediate cath, 110 hours for delayed. More important than survival, some would argue, is did they get discharged with favorable neurological outcome? And again, there was no difference in those outcomes as well. So we went from these observational trials that showed, hey, maybe we should send everybody for immediate cath, to now looking at patients that didn't have a STEMI. These patients could likely wait based on the results of these trials, of this particular COACT trial. All right. The next two, so the abstracts number 4, abstract number 5, and abstract number 6, just are additional RCTs and evidence looking at patients that didn't have a STEMI to see if delayed cath versus immediate cath was necessary in these patients. So abstract number 4 was the PEARL study. This was done in the US and Slovenia. And this was a much smaller study than the COACT study, only about 100 patients that were randomized to early and delayed. And again, no statistical difference in this time they used a primary outcome, a composite outcome of many different things, survival, neurologic outcome, and other things that are outlined in here. But really there was no difference found between delayed and immediate. So if you go back to that COACT trial, one of the really interesting things about it was, I told you there was no difference between immediate and delayed. One of the interesting things about that COACT trial was the survival in that study. 65% in each group, 65, 67%, pretty high survival rates for people that had out-of-hospital cardiac arrest. And then similar neurologic outcomes, about 63, 64%. So the patients actually did pretty well. This was done in the Netherlands, so patients may have been a little bit healthier there, more bystander CPR and that kind of thing. So the PEARL study was done in the US, Slovenia. Not as high as survival in that study, but again, pretty similar results, even though it was less well powered. Abstract number 5 is basically an editorial that also kind of piggybacks off of the PEARL study. And this was the authors of the COACT study. They had an editorial, and one of the things they mentioned was about 45% of the patients in the PEARL study had unstable coronary lesions. That was almost 3 times the number that they found in the COACT study, unstable coronary lesions. Despite the fact that that many unstable coronary lesions were present, still there wasn't a signal of that much benefit for patients that went for immediate cath. Okay? And then the last paper, abstract number 6, the Tomahawk study. This was out of Denmark and Germany. This study looked at the same question. The only difference is the study population. And I always want us to keep in mind who the study population was. In this trial, the COACT, remember we said only shockable rhythms. In this trial, they enrolled shockable and non-shockable rhythms, all out-of-hospital cardiac arrests. And then again, they randomized them to early versus delayed. And what do you think they found in terms of the primary outcome of 30-day mortality? Difference, no difference? Once again, the study sort of re-emphasized the earlier findings, no difference. So bottom line here, in patients with STEMI after ROSC, the AHA continues to recommend that those patients go immediately to cath. But if the patient does not have a STEMI on their EKG post-ROSC, the literature has become more and more robust with more and more RCTs coming out demonstrating that you can wait. I know that when I would call the cardiologist, after I would get the ROSC patients, after these, after the original ProCat studies and when the AHA started to recommend, well, it's reasonable for patients to go to cath after, I would call the cardiologist to discuss with them after every time, and the cardiologists were like, gosh, we're not going to take every single one of these. Some of the cardiologists were actually flustered by these AHA recommendations. Some of them felt that it could be beneficial. Others felt like they couldn't. Certain medical systems actually adopted algorithms that would say, hey, if you had a ROSC and there was no STEMI, based on these criteria, maybe these patients could benefit, but things have become more clear that probably we don't need to send these patients immediately to cath. Okay? And one other noteworthy thing for all of these RCTs that we just discussed is that they excluded patients that were hemodynamically unstable. So if patients had cardiogenic shock, if patients had hemodynamic instability of any form, that those patients were excluded from the study. So if you have an unstable patient, even without a STEMI, and you're concerned about a cardiac cause, I would still discuss those cases with your cardiologist because those patients were not included in these studies, okay? Obviously, those patients need resuscitation and other interventions for their cardiogenic shock, but it does not, those patients may not benefit from waiting for their catheterization, okay? So that was topic number one, out-of-hospital cardiac arrest, coronary angiography. Topic number two, we're going to shift gears. We're going to talk about targeted temperature management in post-cardiac arrest patients, okay? And so do we cool these patients, and how cold do we need to get them? And there's been sort of, the story, the evidence here sort of starts in 2002 when two randomized controlled trials were published demonstrating benefit in patients getting therapeutic hypothermia after their cardiac arrest. These trials were both smaller. The methods were of questionable quality, but those 2002 studies out of Australia and by an author named Bernard, they changed the landscape of how we treated and cooled post-ROSC patients. I'm sure many of you have seen in your own EDs that after ROSC, they would get either cooling blankets down. If you don't have cooling blankets, you could put ice under the armpits and all that kind of thing. And the story sort of remained the same and was actually incorporated into the AHA guidelines. In 2011, the AHA guidelines explicitly recommended that therapeutic hypothermia be deployed every time you have a post-ROSC patient. And it wasn't until 2013 where we finally started to revisit the literature. And so let's go to abstract number 7 here, the post-cardiac arrest syndrome, a review of therapeutic strategies. This paper was a review of the earlier literature in therapeutic hypothermia. And basically the author group that created the AHA guidelines stating that we should use therapeutic hypothermia were also the same authors that conducted the initial studies on therapeutic hypothermia. So there was always a question of whether or not there was some conflict of interest in incorporating these guidelines. But we didn't have any real great evidence to refute it until abstract number 8 came along. The targeted temperature management of 33 versus 36 degrees after cardiac arrest, TTM number 1 trial. This was published in the New England Journal. This was a multi-center randomized control trial completed at 36 European ICUs, and they had about 1,000 patients. They basically did this trial for about 6 months, and they looked at all-cause mortality at the end of 6 months. Patients got randomized to either getting 33 degrees, cooling, therapeutic hypothermia, or 36 degrees, which was controlled temperature management, but not necessarily cool down below what your typical temperatures are. What did they find? They found no real difference in all-cause mortality. 50% in the cool group, 48% in the 36-degree group. Okay? So this began to start putting a question in whether or not we need to necessarily cool people. And sort of the landscape stayed that way for a while until abstract number 9 came along. This is a 2019 paper. This is the Hyperion trial. The Hyperion trial was conducted at ICUs in France, about 25 ICUs. They enrolled about 580 patients. They, again, randomized these patients to getting targeted temperature management at 37 or therapeutic hypothermia at 33. And they looked at 90-day survival with favorable neurologic outcomes. Reasonable primary outcome. What they found was a bit surprising. They found that in the therapeutic hypothermia group, that the 90-day survival with favorable neurologic outcomes was 10% versus only 6% in the targeted temperature management group. So in this paper, it started to look like maybe this therapeutic hypothermia had a little bit of a hint of benefit at 90-day survival with neurologic outcome. So again, should we be going back to cooling patients at 33 degrees? However, when you dive a little bit deeper into the study, the fragility index, which means that if a single patient in that therapeutic hypothermia group had a poor outcome instead of a good outcome, if that patient crossed over into the other group, there would be no benefit, just one patient. So the interpretation was basically, well, therapeutic hypothermia seemed to have a hint of a benefit in this study, but the results and the conclusions were a little bit tenuous. And so fast forward to 2021, June of 2021, the New England Journal published the TTM2 trial. That's abstract number 10. That's the Targeted Temperature Management 2 trial. This was the largest study to date on this topic. And we were hoping that this would finally put this controversy to rest. They enrolled 1,900 patients. That's 2 times the original TTM trial. It's 4 times the Hyperion trial, and it's about 5 times all the earlier trials. So this is a large data set. And they, again, randomized to therapeutic hypothermia at 33 or targeted temperature management at 36. And they looked at a primary outcome of death at 6 months. What did they find? No difference. 50% mortality in the hypothermia group, 48% in the 36-degree group, and neurologic outcomes were exactly the same at about 45% in each group. With this study, I think that we can say, finally, that there is no benefit in cooling patients to 33. There's actually not great evidence either that patients being febrile is dangerous. We believe that to be true, and there are studies that may hint toward that. But what we know is that we don't want what we practice in the emergency department is to not allow these patients to get febrile. To get the cooling blankets and get them down to 33 and all the resources that would take, I believe is unnecessary at this time in light of all the studies, but we do want to keep them from getting febrile. So if you start getting a post-ROSC patient that's getting up into that 38, 39 range, those are patients that we can consider cooling back down to 36. Conversely, if a patient is hypothermic, we don't need to warm them to the 33 and 36 group for post-ROSC. We'll let them kind of warm up naturally. All right. So that sort of is the second big section. We talked about coronary angiography after ROSC, and we talked about cooling after ROSC. Now we're going to talk a little bit about a very interesting topic. Should we be doing CT imaging, pan scans, CT head, C-spine, chest, abdomen, pelvis, imaging everything after somebody has a cardiac arrest? How many people do that? How many people image everything right after a cardiac arrest, sort of as a matter of routine? It's an interesting question. We have patients that are far less sick than patients that have ROSC. that we do pretty extensive imaging on. Is there a downside or is there a benefit to doing imaging of everything after ROSC to see what we can find? And so this is abstract number 12 sort of explores this question. This is a single center chart review that was done in Florida over the course of 6 years. They enrolled 450 patients who had ROSC after a medical cardiac arrest. And they basically looked at the imaging findings. They found that in about 7% of the patients that got whole body CTs, that 7% of these patients, the cause was identified on the imaging. They found that 5% had intracranial hemorrhage on their CTs. They had about 8% showed PEs on their CT chests. And they noted that 13% of these imaging findings changed their management. So again, this is hypothesis generating, that there are imaging findings that changed management in their single center study, but it begs the bigger question of whether or not is there a benefit to doing this as a matter of routine? And there's, again, no comparator group. Hopefully at some point somebody is able to study this, looking at an RCT, whole body imaging versus not whole body imaging, and seeing what the mortality would be and long-term outcomes would be. We don't have that trial yet. These are just more, this is a study to kind of get the brain going and get some of the controversy going. The next study, abstract number 13, was done in Germany. Again, a single center chart review done in 2016. They looked at 100 consecutive patients with ROSC, except at their institution, all of these patients got whole body CT. And they looked at these, and again, they found that 15% had acute findings on the CT head. They found that coronary artery disease was found quite a bit on CT chest. They found acute PE in 15% of their CT chests. Again, their conclusion was that the whole body CT was feasible and added diagnostic value to their patients. Again, no comparator group. It's impossible to know whether these patients would have done better had they not gotten their CTs. And again, for the ED, do these CTs need to be done in the emergency department? Obviously, these patients are getting admitted. They get OBS, there's workups. We see kind of what type of etiologies they may have. So the big question is, do we need to be shotgunning with a CT whole body imaging right off the bat for all of these patients? Again, the answer is unclear, but these hypotheses are being generated from some of these observational studies. I personally do not whole body CT every single patient. If I have, it's sort of a case-by-case scenario for me. And then finally, the last study is pretty fascinating. It doesn't really ask the question about whether we need a whole body CT, everybody, but this is abstract number 14. It's called Meta-Analysis of Optimal Timing of Coronary Intervention in Non-ST Segment Acute. Oh, sorry, where is it? Abstract number 14 is a single center study. I think I have the title wrong in my notes. But the single center study in Washington, they looked at 39 patients with ROSC, 2/3 which had a non-cardiac cause, and then they looked at the imaging results after CPR. What they found was remarkable in how much damage the CPR did. 85% of these patients had rib fractures, an average of 9 fractures per patient. 31% had sternal fractures, 10% had pneumos, 8% had liver injuries. So just on the basis of doing CPR alone, the amount of damage that we can cause from doing CPR is remarkable and notable. And again, no big high-quality RCT has been done on doing this whole body imaging, but it is an interesting question for us to start to think about. Hopefully the next time you guys come to an EMA course, we have a better trial that looks at the utility of doing this practice. All right, so in summary, coronary angiography after ROSC, STEMI, yes, go to cath. No STEMI, probably can wait for a delayed cath. Therapeutic hypothermia versus targeted temperature management. Targeted temperature management seems to do just as well. The studies are very good quality. I think we can get away from thinking about doing therapeutic hypothermia the way that the evidence stands right now. And number 3, whole body imaging. Just think about that there are a significant number of findings that are found. Whether they lead to good clinical outcomes for the patients as a result of it is still to be determined. All right, thank you very much.